Hi, my name is Richard Baxter, and today we're going to talk about integrating tongue ties into your office with long-term success. So I am the owner of the Alabama Tongue Tie Center in Birmingham, Alabama. I'm coming to you live from. I did write the book Tongue Tied with a team of specialists, and we receive royalties from the sale. All those royalties are donated to charity. We have an advanced live patient course at our office monthly. That course fee is also donated to charity. And we have a comprehensive online course, Tongue Tied Academy. That course fee is also donated to charity. So I have no interest in any dental or laser companies. I've not received funding or honoraria from any companies. So actually the English version of Tongue Tie, you've probably seen it, was launched at ICAP 4 years ago in 2018. It's available on Amazon, or you can get the English ebook version for free at our website, tonguetieal.com/professionals. We also have a few different translations now in the last 4 years. We have Lingua Atada is the Spanish version. Frein de Langue is the French version. I'm going to butcher this one. Jezik Nawizi, I don't know. Is the Polish. Strömt Tungeband is Danish. And then Sheshidai is the tongue-tied in Chinese. So anyway, you can get those on various places like Amazon. And Tongue Tied Academy, this is what I did during COVID. It took a year to write the script for this, and then it's 25 hours ADA, the dental credits approved. It's broken up into small pieces, but yeah, it's the A to Z of tongue tie treatment. We have a light version too for therapists. But here's my family, my wife Tara, and then our 3 girls. So we have Noelle on the left, Hannah, and then Molly is our 3-year-old. And then that's how I got in this mess in the first place, because our twins had it 8 years ago. So here's our office. Speaking of 8 years, just a couple days ago we celebrated our 8-year anniversary of the office. If you're doing the math, it was a busy summer with having the girls in June and the office opened in August. But yeah, there's the office. Here's the inside. It's kind of like a Kids Around the World / Global Missions themed office. But we have a playground outside. We were getting so busy doing tongue ties, we had to do the Tongue Tie Center. Added it on, and we have people come from all over the world, all over the country, to help them with oral restrictions. So we talk to the parents, see what's going on, get a good exam. This is pre-COVID anyway, but this is staged, obviously. And then we release when indicated. So a few quotes to start us out with. Half of what we're going to teach you is wrong, half it is right. Our problem is we don't know which half is which. And this, interestingly, comes from a Harvard Medical School dean. Basically with medical education, dental education, speech therapy, lactation, pick your program. They teach you the best at the time, but a lot of things, especially since evidence-based medicine didn't come out till the 1990s, a lot of things in the textbook, there's no references to back it up, and it may or may not be correct. From Rajiv Agarwal, he's a pediatrician. I think he's speaking at ICAP. He spoke last time. But he says, your eyes do not see what your mind does not know. But once you've seen it, it's impossible to unsee. And so today, and if you're watching this, you've been at ICAP, and I think you've had your eyes opened already, but just in case you haven't, there might be something that you see today that you realize, oh my word, like that's different than what I thought it was, and then you can't unsee it after that. And then Emerson said, the mind, once stretched by a new idea, never returns to its original dimensions. So a few treatment pearls to start us out with. We always work with a team approach to care. All proper diagnoses start with a proper history. Misdiagnosis comes from not listening and not examining fully. Listen to the patient's story without interrupting. Empathize. So that's hard because I think the average time between interrupting for a provider is 12 seconds. They've done studies on this. So sometimes it's 15 minutes. Just try not to interrupt. Let mom tell her full story. We review all the symptoms systematically, one by one. We take notes. Examine properly, so that does include gloves and then tools as needed. So like a mouth prop for a 2-year-old so you don't lose a finger. Symptoms and function are more important than the appearance. So you'll hear that several times today. We always image all areas of concern, so take photos. That's critical, especially for legal purposes, as well as to educate parents, and then they can take those photos to their healthcare providers or sometimes to grandma to see what's going on. We always discuss the findings with parents and then make a plan. Release fully and precisely if indicated, or refer to a knowledgeable provider. So if you're not going to do it, or if it's like a 2-year-old, you don't want to do that age, I'm going to show you why it's helpful to do 2-year-olds, but if there's an age you don't do, or adults maybe, refer to a knowledgeable provider. And then you have to follow up at 1 week minimum, and then more often as needed. So proper examination technique, you come from behind. We use loops and a headlamp so we can see everything, but come from behind, then mom can see as well, and check the baby, check the toddler. We check all ages up to about age 10, just using a baby board. If they're older, we'll lay them back in the dental chair, or we'll use just like the recliner in our treatment rooms, in our consult rooms. But yeah, that's key. If you don't look properly, if you just look from the front, you're probably going to miss most of the less obvious tongue ties. And here's a child demonstrating the proper use of the molt mouth prop. And so you got to make sure it's resting on the teeth, and she's not pinching her lip, but it doesn't hurt otherwise. They just don't like it because you're messing with them and they want to move around. But yeah, without a molt mouth prop, you're not going to get very far on a 1-year-old, 2-year-old, some 3-year-olds. So you can get those on eBay. We'll show you that later. So it is a spectrum of lip restrictions. So it can be minimal. This is probably the smallest lip tie I've ever seen, up until the tightest, shortest lip tie I've ever seen. Anyone who says lip ties don't exist maybe haven't seen some of these that are notching the bone. But the key for a lip tie is it needs to be blanching the tissue. So like this one on the upper left, that one may be okay. You don't have to use laser every frenum. It depends on what's happening. If you lift the lip up and the child's like fighting you, there's distress, it's blanching or turning white, there's a notch in it, like on that bottom one. This one has like cords in it. Let's see how white that one is. It can be thin or thick. It really matters is the symptoms it's causing and then the feel of the tension. Often they can flip up to the nose, or they can't flip up to the nose, but not always. And then the symptoms we're going to talk about in just a second for babies up to children and adults. So the tongue, same way. It can be super tight. That's a baby, obviously. It can be thin in about 80-90% of the way. It can be almost translucent, so very thin. And so these ones often are just clipped with scissors, like a frenotomy, but then often they leave the thicker part in the back, the posterior part of it, and that limits the mid-tongue elevation, which is critical for nursing, bottle feeding, speech, solid feeding, sleep, dental development, posture, breathing, all kinds of important stuff. So we really try to get a full release, because most of the time with a clip, you get something like these two here. Those two were clipped. That is incomplete. You can see how thick that is still. It's very restricted. So a simple clip or snip with scissors is often not enough. Sometimes it's enough to help with like maternal nursing pain, but often it does not give the child full resolution of symptoms, and you're leaving some chips on the table that could really impact the child currently or in the future, and the family too. So these ones are less obvious, posterior tongue ties on the bottom. There's so many different classification systems. I kind of just prefer like a percentage. So this one up here I'd say is like 100%. This one down here is probably 10%. Right? If you say percentages, everyone knows what you're talking about. There's not much confusion. Maybe 25% for this one. And a lot of these less obvious tongue ties, so less than 50%, a posterior tongue tie, you really have to lift up well and use 2 fingers to see it. You'll see it pop up there, kind of like an Eiffel Tower. This is the most minimal tongue tie I think I've ever seen. There's almost nothing there, but for that individual baby, it was causing a problem. Say, how do I know? Well, they had all the symptoms of a tongue tie, and when we released it properly, they had lots of benefits a week later. Here is another picture. So this is the same baby. Just lift up a little bit. Notice a little bit of tenting there. Lift up some more. Okay, the fascia is bunching together. That's tighter. Lift up with 2 fingers. Okay, now we've really got a good bit of fascia coming together. And so that's tight. That's probably too tight. Here's in a child. So notice right here, the incisors are turning inward. So that's a clue. Most dentists, if they saw this child on an exam, like a hygiene check, would say, oh, we got a fused tooth down there, but then wouldn't really check for the tongue. But notice how they're turning inward. That's curious. It's also tenting just a little bit. You lift up with 1 finger, you notice it's bunching a little bit more. Lift up with 2 fingers. Okay, now it's getting significantly tighter. And so the issue with this tongue is that, it is restricted, but is it causing a problem? So this is on a hygiene check. So they didn't come to us for a tongue tie reason. They came to us for dental reasons, to check their teeth for cavities and such. So I just asked the mom, hey mom, any speech or feeding or sleep issues? She said, nope, he's good. I said, okay, well, if anything does pop up later, let us know. The tongue is moderately restricted. I said, okay, and then that was that. But sometimes you'll ask the parent and they'll say, oh my word, yes, like we're in speech therapy and he's so picky, we can't eat out. He's the slowest eater I've ever seen. He sleeps crazy, he's kicking me in the head, all these things. So that can all be related to a restricted tongue. We're going to talk about that. But it depends on that individual child. What symptoms do they have, and what's the appearance, and what's the feel? How tight does it feel? So for children, the symptoms and function are more important than the appearance. What do I mean? Well, this one on the left had perfect speech. Now, she had other issues too, like eating issues or sleep issues and like headaches and TMJ issues. So it can cause other things, but perfect articulation. So it doesn't have to cause speech issues, although often it does. This one on the far right was nonverbal. Now, he's also autistic. And so what's interesting with kids on the spectrum or Down syndrome or premature babies, everything gets blamed on the prematurity. Everything gets blamed on the autism. Everything gets blamed on the Down syndrome or 22q or whatever the issue is. But very often with kids on the spectrum or any other child, everything gets blamed on that, and they still have issues from a tongue tie too, if it's restricted. So this one doesn't look bad, but actually look at the floor of the mouth. It's elevating so high that it probably would only lift about halfway if you held that floor of the mouth down. Right? So this child was nonverbal. He was almost 10 years old. We released it. He came back the next week, had several new words, said mama for the first time, was sleeping better, ate salad for the first time. Huge benefits, and there's minimal restriction. But for that individual child, it was too tight. Often we'll have parents say, if there's a 2% chance of this helping, I want to try it for my kid. And so with the risks being so minimal with the laser treatment, outpatient, we're not putting them to sleep or sedating them, just a little bit of numbing jelly. Sometimes we'll inject some lidocaine too, but the risks so minimal, it's opened up the possibility to try these ones that in the past, if you thought, well, I had to put this child to sleep and it's going to be much more involved and a $4,000 bill from Children's Hospital, you may have, not done that before. I think that really that's why in the last few years we're seeing these crazy changes from even minimally restricted tongues, is because we're able to try them without, causing significant risks. And then obviously these are pretty restricted too. So just check. Just check under everyone's tongue. If it's a hygiene check, if you're a pediatrician, it's a well check. Don't just have them stick the tongue out. That's the worst test. So elevation is more important than protrusion. Sticking the tongue out or protruding the tongue doesn't have a lot to do with many functions, licking ice cream cone, playing a wind instrument, French kissing, that kind of stuff. But elevation is important for speech, breathing, sleeping, dental development, posture, breast and bottle feeding. And for the lip tie, we're going to talk about this too, sometimes can be very significant. And most of the time we have people come in for a lip tie because it's more obvious. And the mom will say, oh, my child or my baby has a lip tie. We'll have them fill out the symptom form, I'll show you in a second, and actually they have a lip and a tongue tie. So often, but not always, they go together. But most of the time they do. This one has a dog leg on it. That would be a class 4. It's coming all the way down, kind of wrapping around. These are all class 4s. Sometimes you can have cavities on the teeth. Now, the lip tie doesn't cause the cavities, but it can predispose them to cavities because if it's harder to brush up there, the child's fighting real bad. It can also trap milk or food up there. We've seen that before too. So that can all cause problems from a lip tie. So you may have heard the common phrase like, oh, I don't release the lip tie until after braces because it can cause a gap and scar tissue that will prevent the gap from closing with braces. So that was from an article. It was written a long time ago, but most recently cited was a Bashara 1972 article, so 50 years old. And what's unfortunate is that article never once mentioned scar tissue. But that's the article that's cited for people saying, oh, don't do it because it's going to cause scar tissue. In fact, the article says every effort should be taken to prevent the cause of the diastema if that's possible. So I'm here to tell you today it is possible and predictable to prevent a diastema or a gap in the teeth if it's treated properly. So we looked at all the patients treated from 2015 to 2018 that had a follow-up visit, like on hygiene. We got a picture of them, or we had them send in a picture, as many as we could that had teeth. So not babies and not kids without gaps, all that kind of stuff. Kids with a gap. And so we looked at 192 total. 109 we could actually get them like a follow-up picture. It's very hard when doing research in a private practice to get people to follow up that kind of stuff. But what we noticed was we measured the gap digitally. So you can use your X-ray software, measure it digitally, and calibrate it, that kind of stuff. The width decreased in 103 out of 109. So almost 95% of patients, the width decreased. Half are with CO2 laser, so we use a light scalpel. Half are with a diode, so a hot tip. We can talk about that later. But 13 had permanent teeth. 96 are with primary teeth. So that's the key. These were done in early, childhood, maybe a 2-year-old or a 3-year-old or 18-month-old, and the gap closed up almost always. We just got this published in International Orthodontics back in March. So it took a little while to get this published because there's such a strong publishing bias against any kind of like pro-tongue tie or pro-lip tie thing. If I had said a lip tie causes scar tissue and don't ever do it, it would have gotten published right away in like JADA right? The Journal of the American Dental Association. But since I said, hey, a lip tie does not cause scar tissue, no one wanted to publish it because it goes against the dogma that's been around for 50 years. Thankfully, we had a publisher that was willing to take a risk on us and publish the actual data. So just know that if you do research, if it shows a positive effect for lip and tongue tie, it's much harder to get it published than something like the Callaway 2019 article that said, oh, like tongue ties don't make a difference and lip ties, the Cotler rating scale doesn't work. The Santa Maria article, all those, they get published very easily because they're, going along with the narrative, so to speak. Here's a child. So large lip tie, huge diastema. So that's a diode release. See, it kind of looks like charred and stuff there, like burned almost. You'll see later the vaporization with the CO2 laser. But anyway, it still works beautifully. Look at that. Healed really nicely. The gap closed up. 6 months after that, the gap closed even more. We're not trying to get the gap closed completely because you do want some spacing between the baby teeth, but we do want a normal distribution, not big gap and then no spacing, like in the first picture, big gap and then no spacing. That's not what you want. We want even distribution now, and that's without braces, obviously. Here's another child. So this one was done with a CO2 laser, so it has a different appearance to it. It's just gone, just vaporizes it. So we released all this down here, and the key is you have to get the part right between the teeth, the papilla there. And then the teeth came together without braces. Here's the article. So safety and efficacy of maxillary labial frenectomy in children, a retrospective comparative cohort study. So if someone tells you, oh, it'll cause scar tissue, you can say, well, what evidence do you have for that scar tissue? They'll say, well, like they'll point you to Wheeler 2017, which is a opinion article. They asked a survey of some oral surgeons and pediatric dentists and orthodontists, but that's a survey, so that's like level 5, maybe level 4 evidence. This is a cohort study, so that's level 2 evidence, right? So in the hierarchy of evidence, this trumps all these other things other than a randomized control trial. But anyway, all that to say, we got it published. That was really exciting to get published in a high quality, not a pay-to-play journal. So here's a few more pictures. Notice the gap, and then it closed up. Gap and closed up, gap and closed up, gap and closed up. So anyway, it closes up. Here's I think it was like 11 or so, 10 or 11 when we did it. Large diastema, it's real meaty. You release it, again, getting that portion right here. You can't just cut this with scissors one time in the middle right there. It won't work. And I think that's what happened in the past. It was just cut with scissors and didn't work. But anyway, you cut in the middle. Look at that. See how much nice it came together? And then beautiful smile saved him $6,000, right? That's how much braces would be, ballpark. And so, yeah, mom was very happy, and that's a nice service you can provide for kids and their families. Here's our infant assessment sheet. And so this was originally made by Dr. Kotlow. I made a few changes to it, namely changing out the where they're located. So the top form is the baby's information, baby symptoms. The bottom is the mom's information, right? Or like what symptoms they're having. Again, what we had was moms would come in and say, my child has a lip tie, but the tongue is fine. And I look in there and the tongue is tight, but it was hard for them to see that. We take some pictures and they could see it better. But now we separate it out. So these things are predominantly, not fully, but these are mostly tongue tie symptoms over here on the left. These are mostly lip tie symptoms on the right. And so that helps a lot. So the tongue tie, the tongue's the motor. So like the shallow latch, falling asleep, popping off and on the nipple, gagging, choking, coughing when they eat. Again, these things are common, but they're not normal, right? Poor or slow weight gain, doesn't have to be, but it can be slow weight gain. We had a 6-month-old baby yesterday that weighed 9 pounds. That's a problem. Hiccups a lot. Lots of in utero hiccups. Probably the earliest sign of a tongue tie. Excessive in utero hiccups from a dysfunctional swallow because the tongue's holding it down. Gumming or chewing the nipple. Passy won't stay in. They can't cup properly. Snoring, noisy breathing, mouth breathing. Airway issues start at birth and really in utero with the palatal molding. Short sleeping, waking up a lot. They move a lot in their sleep. They seem always hungry. Those are more tongue issues. The lip is the seal, right? The seal issues. Lip tie, possibly buccal ties, contributing that too. But the lip curls under when nursing, clicking or smacking noises. They swallow air. Air gets in the belly, has to go somewhere, so it comes up as reflux or spit up. It goes down as toots. And while it's in there, it rumbles around, makes them colicky. Colic is a symptom. It's not a diagnosis. It's actually a diagnosis of exclusion, meaning you've run through all possible other diagnoses to see before you give them the colic diagnosis. Unfortunately, parents are just told, it's colicky, it'll get better the baby's colicky, it'll get better in 3 or 4 months. That's not the best option. Most of the time, the baby's trying to tell you something. They're uncomfortable from the gas in their belly, or they're not getting enough milk, or both. Most of the time, not always, but most of the time, a tongue or lip tie is to play. And make sure they've seen a chiropractor too, or like physical therapist, CST, that kind of stuff. Body work can definitely help with that too. But often there's a lip or tongue restriction. Milk leaks out of their mouth, nose sounds congested, they get frustrated at the breast, and then constipation or irregular stools. We see that a lot too. For moms, nipple distortion, nipple damage, terrible pain, although it doesn't have to be. What's interesting is the 7+ pain is most of the time a posterior, not obvious tongue tie. Not always, but again, looking for patterns, most of the time that bad pain is a posterior, not obvious tongue tie. And then moms think they're crazy because they're like, oh my gosh, I have all the symptoms of a lip or tongue tie, but my pediatrician, my lactation consultant, my whoever, or ENT said there's nothing there, right? And you're making broad generalizations. I know there's ENTs like Dr. Gahary, Dr. Zaghi, pediatricians like Dr. Agarwal, well, others that are well-versed in tongue tie. But on the whole, most dentists, ENTs, and pediatricians are not well-versed in tongue tie because of a systemic lack of education on the subject. And so you can help educate your providers in your area now after seeing this and other presentations. So what's interesting is too, feelings of hopelessness or depression. We added this one and then added this question right here. How are you doing mentally, emotionally? Because it does take an emotional toll on the mothers and the fathers and grandma too, and siblings. It really affects the whole family when a baby is tied. And so these issues can cause parents to be on the struggle bus, like they are really struggling. We've started checking now more for postpartum depression with the EPDS-10 screening for postpartum depression, and every day we have at least 1 or 2 moms score above a 10, which puts them at a high risk for postpartum depression. Not get all the milk out, milk supply issues, mastitis, engorgement, plugged ducts, nipple thrush, using a nipple shield, and prefers one side over the other, and often that's a body work issue, but it can resolve after the tongue tie too. So, what are we doing for these babies? Are we just looking at the fruit and the obvious things, right? So the baby's gassy, here's some gas drops. They're colicky, here's some gripe water. They're not feeding well, or it hurts, here's the nipple shield. Not getting enough milk, here's some formula. We're just treating the symptoms, right? We're just symptomatic treatment, and basically we're giving them Band-Aids. We have a family pack of Band-Aids. We have lots of Band-Aids. But we have to look deeper. What's the root cause? Why are these things happening, right? For kids, it doesn't get better with age. It just changes. So the symptoms don't go away, they just change. So for kids, mainly what we're looking at is 3 main areas: speech, feeding, and sleeping. We want to know the history of issues as a baby, like what did they have as a baby, so all those things there. And then we have this kind of catch-all, like other. So speech would be frustration with communication. Parents or others have a hard time understanding them. Trouble speaking fast, getting words out, trouble with sounds, especially R's, L's, S's, SH sounds, TH sounds, that kind of stuff. Speech delay. Our article in 2020 was the first to show a connection with tongue tie and speech delay. Stuttering. We've seen some crazy examples of adults with lifelong stutters improve after it was released. So people that say, like ASHA, the American Speech and Hearing Association, their official policy is, oh, tongue ties don't impact speech. Because they'll see, one kid with a to-the-tip tongue tie. We had one the other day. She was 11. To-the-tip, perfect articulation. Right, she figured it out. Most kids with that cannot figure it out. But we have a lot of kids with posterior, less obvious tongue ties with terrible speech delays, like 3 words at age 3. That's a problem, right? Mumbling or speaking softly, baby talking, frustration with eating, trouble transition to solid foods as a baby or 1-year-old, slow eating. They eat like a bird sometimes. They have a small appetite. They graze on food. They pack food in their cheeks like a chipmunk. Real picky, especially meat and mashed potatoes. Probably 90% of the time, it's meat or mashed potatoes. They choke or gag on foods or on water. Spit out foods, trouble trying new foods. Constipation can be impacted too. If your food doesn't start the journey right, it won't end the journey right. Reflux, and then the families can't eat out. It affects the whole family. Sleep issues. They'll sleep in weird positions, sleep restlessly, wake up easily or often, join mom in bed. They'll wet the bed even if they're 10 years old. We've seen that resolve like the same night often. They wake up tired, just poor quality sleep. Teeth grinding, used to think it was psychological. It's actually physiologic. So if you're trying to breathe and you can't get enough oxygen, your brain tries to put your jaw forward to a more forward position to open your airway. Often they'll toss and turn to try to get in a better position to get more air. That's why they're kicking and moving around at night. They'll snore while they're sleeping, and they'll gasp for air even. Other issues, the neck or shoulder tension, mostly in adults, but some kids we've noticed that too. TMJ issues, headaches or migraines, strong gag reflex, like mouth breathing, thumb sucking pacifier use, because that tongue is not resting on the palate, not stimulating the nasopalatine nerve. The kids don't feel like grounded, at peace. Tonsils or adenoids removed. Often that's from mouth breathing. So the mouth breathing, because the tongue is held in a lower posture, can lead to mouth breathing, which can cause microtrauma and irritation to the tonsils, which often, not always, this isn't always the issue, but often can lead to their enlargement, and the child's had them out before. Or ear tubes, if they can't, clear the eustachian tube as easily, because the salpingopharyngeus muscle is not activated as much, because their tongue is held down, they can get more ear infections and like multiple rounds of ear tubes. Hyperactivity is interesting too. If they're not sleeping well, that can lead to hyperactivity or inattention issues. When I don't sleep well, I have trouble paying attention and more scattered. So it's definitely a thing. You've probably noticed that yourself. And so sleep has a direct impact on hyperactivity and inattention. So if a child has ADD, ADHD, they definitely need to be checked for a tongue restriction. Lip tie. Again, so what happens, parents will come in like, oh, my child just has a lip tie. And they'll check off like several things here, like everything will be checked off, right? If I see a form like that, like, okay, there's something wrong. And then they do have a gap and they have trouble eating from a spoon and it's hard to brush the top teeth. And I'll say, Mom, like all this stuff here, this is all the tongue tie issues. The lip tie is down here, right? And so what's interesting is they often go together. Again, not always. So if it's just a lip tie, they'll mainly only have issues down here. Trouble brushing the top teeth. Top teeth don't show when they smile. It's like held down. They have a gap between the two front teeth. Cavities on the two front teeth. Trouble eating from a spoon, trouble with BP, M, and W sounds, so bilabial speech sounds. Also, an add on there once at some point, like nasal breathing. We've done a lot of adults and older kids that when we release the lip tie, it's easier for them to breathe through their nose because of the fascia release. It's pretty cool. Not always, but most of the time when we release a lip tie at an older child or an adult, they can breathe through their nose easier. When you release the lip tie, it's easier to breathe from the fascial release through the chest. It sounds crazy, I know, but like after 30 people tell you the same thing, like it's probably, you put the turkey in the oven and it turns brown. Like it's probably the heat that did it. Adult, very similar. It's just a little bit different than the child ones. Like embarrassed with communication, they might get shy. The jaw gets tired when singing or reading out loud. I noticed that one before I had my release. Mumbling or speaking softly, trouble with singing. We've done some opera singers, some others that are singers. It's either a CPAP or a sleep appliance, snore, trouble with kissing, stress or anxiety, like that kind of stuff. So jaw surgery in the past, like I had, teeth extracted for braces, sinus issues, like I had, sinus surgery, trouble breathing through the nose. So this is our adult form. And here's our assessment. Basically, we'll fill this out for every patient. This one's nice. It's adapted from Dr. Kaplan, but basically I took that one and I made it applicable to all ages. So lip ties, stuff is up here, infant lip is up here, buccal ties, tongue evaluation for babies, anterior, posterior, and then adults or teens, here's the functional grading, compensation, what's their palate look like, what's their intermolar width, is their tongue overflow, tongue scalloping, is the soft palate visible, so all on one page. I'm all about like keep it simple, but like still getting all the information you can get and need. So that's why I like the one page form for the symptoms you see at a glance, what they have, one page for the evaluation, what they have. And so the floor of the mouth compensation, this is really helpful too. This changed a lot of ways we see tongue restrictions because before we say people come with all the symptoms and so we would release it, but it didn't have a good way to like measure the difference because they could lift up really well afterward. It was like a grade 1 before and after, right? But what they were doing was they were lifting the floor of their mouth. So after Dr. Zaki and others brought this to our attention, this really helped a lot. Notice how this guy's lifting the floor of his mouth up. So you can use a gloved finger and hold down right behind the incisors, and then you can see like, okay, now that's his true mobility is maybe like a grade 3. He lifts like 45% instead of he's a grade 2 lifting, 70% or whatever. Anyway, so it can help a lot. And then you can see afterward in the before picture, holding down, they can only lift a little bit. Afterward, hold down again, they can flip all the way back. So that's key. So here's an opera singer. She's 39 years old. Obstructive sleep apnea since 2017. Again, lots of sleep issues. Look at that. CPAP, compensating with singing, trouble with S's and Z's. She's did speech therapy. She's doing myofunctional therapy. We don't release any adults or teenagers unless they're doing myofunctional therapy. She was bottle fed as a baby. She grazed on food throughout the day. Mouth breathing, neck or shoulder tension, TMJ issues, strong gag, reflux, constipation, stress or anxiety as long as I can remember, some depression, and don't hold chiropractic adjustments well. And she's, again, her profession is she's an opera singer. So that's kind of important for her job, to use her tongue. Her lip is not bad. So years ago, I would have not even touched the lip. In fact, she actually fell and ripped it at some point. There's a little ball of tissue there. She fell and ripped it. Her teeth are together. I would have just left it alone. With her singing, she said she had a lot of tightness in there. Her myofunctional therapist noticed that too, and then trouble breathing through the nose. So we've released it. It's a simple release. It's, maybe 30 seconds or so on an adult with the CO2 laser. We numb it up first, obviously. And then the tongue, here's her tongue. So notice the compensation. So at first, lifting up, she looks pretty good. She's like a grade 2. She can lift up pretty well. But look how much her floor of the mouth is lifting. When I hold that down, now she's like a grade 3. So that's her true mobility. Well, look after. Holding down after the release, whoa, she's at grade 1. She can lift up great. Holding down after we sutured it closed. So adults and teenagers will suture them closed with chromic gut suture. Still lifts up amazing. So way better than before. She can open wider. Like, she was very happy. So here's 1 week later. Singing is easier. Less moving at night. Less need of a sleep appliance at night. Less grinding teeth. Easier with sounds like ah. Hard to clean outside bottom teeth, but tongue can reach further. Less neck or shoulder tension. Less TMJ issues. Less mouth breathing during the day. Would you do it again? Singing is easier. Less jaw tension. Posture's much improved. Less tension in her neck and shoulders. She was very happy. So, how do we figure out what kids or adults need this? We need some kind of a screening tool. So it has to be quick and easy to implement, or else what's the purpose? It has to combine the symptoms, the function, and then the parent or the patient's desires if they're older. Should useful and reliably predict related issues, and then we should always prevent treating if there's no issues. We never want to over-treat or under-treat. We try to get right in the middle. That's our goal. So the first step of screening is using the tongue range of motion ratio. And there's the tip, so tongue to incisive papilla, and then there's LPS, lingual palatal suction. So basically, we're mainly using the tongue range of motion ratio to the tip, so see how high they can open their mouth, how high they can lift their tongue when their mouth is open to a comfortable mouth opening. So if it's less than 25%, that's a grade 4. That's what we were talking about in the last slide. If they lift less than 50%, that's a grade 3. Grade 2 would be like 50 to 80%, and then over 80% would be above average grade 1. But some people with a grade 1 or 2 could be compensating, and they could still have issues. So that's why I have to look at the whole picture, not just how high they can lift their tongue. Someone with a grade 4, it wouldn't take many issues for us to say, yeah, you probably need to have that released because it's significantly limited. Lingual palatal suction is very similar. Greater than 60%, grade 1, 30 to 60, grade 2, less than 30, grade 3, unable to, or less than 5% of their mouth opening would be a grade 4. So we combine how high they can lift their tongue or hold their tongue with the symptoms. So our original form was this one. This is the Tongue Restriction Questionnaire, or TRQ. You can get all of our forms on our website at tonguetieal.com/professionals. The baby issues are here. Child to adult issues are here. This is basically the greatest hits of our previous forms that I just showed you. But then we realized we're not going to treat it now for an issue in the past. So we took away the baby issues. And then the bottom was, so we took this away in the revised tongue restriction questionnaire. And then the tongue elevation, we looked at that. Referral recommended that basically if we saw them in hygiene, should we refer them to the tongue tie center, like do a more in-depth consultation? Because you can't do a 30-minute consultation during a well check or during a hygiene check, or your hygienist or your nurses will hate you, right? So we have to look at the whole picture, but we need more time to do that. So what we found was we did the revised tongue restriction questionnaire. So this is one we use in the office now, but basically any issues that are a problem, check them off here. How significantly do they impact quality of life? So that's important because if you have several things like picky eating or I don't know, like mouth breathing, but they're not at all impacting quality of life, at least is not perceived as a problem, mom is probably not going to want to do it. Unless it was a grade 4 and very tight, and then she might be, okay. So that's why it's important. But if it's just a few things, and it's like a grade 2 or grade 1, and it significantly impacts quality of life, well, now there may be more reason to refer. Does that make sense? So that's how we look at this. Basically, it's to facilitate a conversation between the doctor and the hygienist or whoever, the lactation consultant, and the patient to see, is it worth sending this child or an adult for a release. So we got this published in March of last year in Compendium, but basically, yeah, the tongue restriction questionnaire. It's not called tongue tie questionnaire because people think that a tongue tie is just when it's to the tip. And so like a restricted tongue, like, oh, okay, like it can be halfway restricted, right? It doesn't have to be all the way. So here's a few things, tables from that article. What's interesting is, again, common does not mean normal. So just because snoring is 30% of the kids said they snored, does not mean it's normal. So this data, the way we got it was we asked our hygiene patients. So they're not here for tongue ties, they're here for dental reasons, so just a normal population. And had them fill this out, and then we had the hygienist check their tongue elevation, and then I checked the tongue elevation. We compared them to see if it was reliable and valid. And then we looked at how many symptoms would a child need to refer them to the tongue tie center, right? So picky eating is common, restless sleep is common, mouth breathing is common, trouble with speech is common, teeth grinding about 20% of the kids, slow eating 15%. So these are the most common things we noticed, right? Out of 300 kids that we assessed. The tongue grade versus the number of symptoms. So if it was a grade 1, they could lift up perfectly, but they had like 10 check marks on that form. We're like, hey mom, it's probably worth like getting them checked out. Conversely, if they barely lifted up, but they only had just a few symptoms, like 4 symptoms, we're just like, yeah, you probably still want to get that checked out. So that's the average number of symptoms. A few just quotes from there. So babies with symptoms left untreated are more likely to have higher symptom counts as children. So treat babies if there are problems. Again, because they check off all the, oh yeah, it was terrible as a baby and now it's terrible issues as a child. Highly significant. And they're more likely to be referred as children for further assessment and treatment. Highly significant. Babies should be appropriately screened for common symptoms of tongue ties and then treated as a baby if there are issues. You can hopefully prevent future issues. Walls 2014 also looked at that with speech with 3-year-olds and whether it was treated as a baby, no tongue tie, or left untreated. And then also a high percentage of patients whose parents thought their referral would be helpful. So 26% of the parents thought that a referral would be helpful because their children had poor tongue function as well as significant quality of life issues, more than 10 in many cases. So it's common, but just because something is common does not mean it's normal. So if people ask me how common are tongue ties, I'd say probably about 25%. Where do I get that number? From right here. Some studies, like in Brazil, Martinelli Marcusson said it was 32.5% of the babies after lifting up properly to check for posterior tongue tie had a tongue tie. Most studies would say 4 to 10% of babies have a tongue tie, but that's not including posterior tongue tie. Some pediatricians that check babies at the hospital that see all the babies in the newborn nursery say it's probably 30% if they're checking appropriately, have some degree of tongue restriction. So the ones that grow up and later have issues, it's probably about 25%. That number could be low because we've treated a lot of our patients from hygiene already that had a tongue tie. So here's another article we put out in 2020. This is a prospective cohort study, meaning before we even saw whether they had improvements or not. Hey mom, y'all want to be in the study? Yes or no? They're in the study, and then no matter what happens, if it gets better or worse, we're reporting the data, right? IRB approval, all that stuff. So it's published in Clinical Pediatrics, which is also a good journal. 37 children we got follow-up on at 1 week and 1 month follow-up. Average age was 4 years old, so these are, like preschoolers, but some kids were older, 12 years old, and then some were younger at 1 year old. But significantly better speech, solid feeding, and sleep at 1 week and 1 month follow-up visits. Our first article in 2018, sleep and feeding improvements after posterior tongue tie release. Lauren and I did that. Lauren Hughes was a myofunctional therapist at our office for a few years. Now she's so busy, she's down the street. But that was the first article to report on solid feeding and tongue ties ever. There was literally not a single article on solid feeding and tongue ties. This is the first article to really draw more attention to solid feeding, as well as some other things like speech delay has never been reported in the literature, positively or negatively, even though like Nelson Textbook of Pediatrics, one of the pediatrician textbooks would say speech delay is not impacted by tongue tie, but they didn't have any reference to back that up. They just blanket statement, it doesn't impact it. Picky eating, slow eating, choking, snoring, restless sleep. This is the first article to report improvements with that in a prospective cohort study. So that's level 2 evidence. So if someone says, oh, speech delay is not impacted, that's your opinion, that's level 5 evidence. Show me an article that's, a research project that is well done, that they did a proper release that didn't see improvements in speech delay, right? It's not every child with speech issues, so 89% had improved speech. So some may not have had speech improvements right away. They might have with speech therapy improved. And some may have not have had speech issues at all to begin with. But still, 89%, so that's most of them. 83% had improved solid feeding. 83% improved sleep. 90% said they're happy with it. Some were unsure because the stretches suck. So for parents, I'm like, okay, the deal is like the stretches suck, but should be worth it. Because most kids get something. They might have gotten sleep and eating, but not speech. Or speech and eating, but not sleep. It's kind of random. It's variable what you get. So that's only if you do the procedure right, though. So the procedure has to be done properly. If you cut into the body of the tongue, like this one was cut in the body of the tongue, that's not going to work, right? You have to release it properly, halfway between the body and the Wharton's ducts, and then you get a full, nice release, a lay flat diamond. This one was clipped at some point, Mom said. I don't know when. This child's in braces, but said as a baby was clipped. Look how tight that still is. That's unbelievable. Look how much higher it lifts now, right? This one was clipped in the middle and there by a pediatric ENT in our area, but again, it didn't do anything for the parents. They came to see us. We fixed it. This one was cut into the salivary ducts. You don't want to do that. They cut way too low. You need to cut in the right place. We had to go above this one and come down like that. So we see this, unfortunately, every day. At least we have someone that's been clipped. Look at how restricted this one still is versus afterward flips all the way up. Same thing, still very restricted, lifts all the way up. This one, it does not stretch out. It does not go away. This is a 36-year-old we released. Just a little bit right there is all they cut at first. And then boom, like way higher, right? Significantly increased. Largest lip tie they left untreated. This one they cut really bad into Wharton's ducts and gave him 4 openings. She's actually 4 years old now. She's fine. She lived. That's a joke. But what's interesting is she didn't have to have any kind of like oral surgery to like recannulize like her salivary ducts. It did work out okay. But don't cut there, please. Cut above. So we had to go above and then come down on that one too. And then she has much better mobility now. So this is where I'm coming to you live from one of our consult rooms. Originally, it was just my office. Then I got my office back after we built the tongue tie center. But we use a scale. We do weighted feeds for babies, enough room for mom and dad. And we had like 10 people in one of the rooms yesterday. We had a live course with 3 doctors here. And then we had they had 8 children and then mom and dad. So it was, a lot, like 12 people in one of these small rooms. We use a swaddle, the Swaddle Me. Need a knee lap board. Sometimes they go out of stock on Specialized Care Company. If they don't have them, just call them and harass them, to please make more of them because they're really helpful for the procedure as well as for the consultation and laying the baby back. We use a anesthesia donut. So diode laser, this is the BioLace iLace. We use this for 18 months. It works. It takes about a minute per area. It seemed like we had more pain intraoperatively as well as postoperatively. So I would actually inject, even like on babies on the lip tie, because I felt so bad for them. We don't want to ever hurt a baby, obviously. We're doing it for them, not to them. But I could tell it was hurting with the diode. We switched to the CO2. The laser's not in the picture there, but this is our current setup. We have a mouth prop if it's a child, laser safety glasses, really just like the laser handpiece and then suction and some gauze. It's really simple. This clamp is helpful. If you don't have a second assistant to help out, you can get this, it's called a clamp. That's for macro photography to hold like a flower or something while you're taking a picture of it. That's really helpful to hold the suction to suck up the laser plume. You don't want to breathe that in. Again, we're talking about success, long-term success here. So I don't want you breathing in carcinogens and benzene and like that kind of stuff that's in the laser plume, DNA fragments. You want to suck that up and get it out of there. The 3.5-inch mouth prop you can get for $5 on eBay. Those are really helpful for children and babies, even like an 8-month-old baby. If they're chomping on you, you can use that. We'll send it home with parents of toddlers because I don't want them to lose a finger, so that's helpful too. So 5 keys for a proper release. 1, anesthesia, precision, tension, look and feel for fascia, and then the size and shape. You don't get too wide or too narrow, so we'll talk about those. Anesthesia. We want everyone to be comfortable so we can get a full release and always cause the least amount of pain, right? Dentists, we're not trying to cause pain to people. Some people think that dentists just try to cause people pain, but you can use scissors or scalpel. You can use cautery. I'll use electrosurge at the hospital. It works well, but they're asleep. We're doing a dental rehab and they need a tongue tie. We'll do that. We don't put children to sleep just for the tongue tie or lip tie procedure, though. It's in the office. It's about 15 seconds with a CO2 laser. It introduces extra risk that's not needed, in my opinion. Diode laser, again, we use that for 18 months. Not to hate on diode lasers. It is a hot tip, gets to 700 to 1,000 degrees Celsius and burns the crap out of the tissue. Cautery also burns the tissue. It can go deeper into the tissue as well. And so it can have various effects with the heat-based methods. Scissors, obviously, would just be what you cut, but the scissors, it can bleed more. And so you're looking at, trade-offs with the various tools. What we found, what most people find, is that the CO2 laser has the best advantages. Disadvantages is expensive, $30,000, $40,000 or $150,000 if you get a Solea. But light scalpel is around $30,000, $40,000 for CO2. And so the wavelength, you get controlled, efficient cutting as well as good hemostasis. Versus an erbium, that's also an option. It's not on there. Erbium lasers, mostly used for hard tissue, but can be used for soft tissue. Good cutting efficiency, but they have poor or not as good hemostasis as the CO2. Diode would be poor cutting, but good coagulation or hemostasis. So the CO2 laser has the best of both worlds, essentially. It's often 10 seconds or less. Strong topical is what we use for everyone. Babies will use EMLA. If they're over 12 months, we'll use lidocaine, prilocaine, tetracaine, compounded topical. We will inject lidocaine if they're 5 or 6 years old, and I think that they'll sit still for the pinch, and if they feel a little pinch, they're not going to freak out on me. Yeah, here it is, age 4. So it depends on the child. Again, not too high, not too low. Showed you those before. Don't cut in the wrong place. Don't hit the salivary ducts. That's not good. Again, previously clipped, you don't want to get those. So here's tension. We want to make sure we get lots of tension is the key. Circle around right at the insertion point of the freedom until it starts to give way. Lots of tension, slow hand speed, close tip to tissue distance, about 1 millimeter or 2 away. Then you chase it as you go. That's the key to using CO2. This is the light scalpel. I'm not paid by them. I don't get money from them or any laser company for that matter. I paid full price for my laser. So there it is, releases all the way, and now it lifts much better. No tension, no bleeding. If you tell the parents there'll be no bleeding, it'll bleed a lot. So just say minimal to no bleeding. Posterior tongue tie, 3 seconds. Right in the middle, 1, 2, 3. Just back and forth a few times, and the diamond shape opens up naturally. We got the fascia and the mucosa. We do not take muscle on babies or children. Sometimes on teens or adults, we'll take a little bit of the genioglossus muscle. So size and shape. So we're going to lift up a lot. And I leave this slide because I actually go more conservative than this now. This slide's several years old. It's probably 5 or 6 years old. But basically, I'll probably keep it to that now. Make sure you get this part down here. That's critical. You don't have to go as wide right here anymore. It's just going to heal back together anyway. You probably get more swelling of the lip as well. Start in the middle of the tongue. So the bottom, start here, go around, and then go side to side like this, slowly, 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 until about there, and then you're done. So that's okay. This one's a little bit too wide. It's wider than I go currently. The tongue is not bad. I might have taken a little bit more on this side if I had to critique it, but that's a good functional release. Don't worry if you're just getting started on getting like a perfect release. They say perfect is the enemy of good. They told us that in oral surgery. So you try to get just perfect, and then you go a little bit wider here, and then, oh crap, you hit this big vessel, and then it's like pouring out blood everywhere, and then you're like, I should not have done that. So get it good, a nice release, but to get it perfect, sometimes you'll mess it up. So don't do that. Not here. Do not go too high or too low. You want a nice diamond shape afterward. So the diamond shape. A frenum is a triangular prism. When a horizontal cut is made through a triangular prism, 2 triangles appear, giving you the diamond shape. If you cut horizontally, you will naturally get a diamond. You don't have to make a diamond. Here's a 3-month-old. So this just shows you how we feel for the fascia. So again, start right at the insertion point, hover back around, around, around. We're going up and down at very slow hand speed. Again, these babies are crying, they're awake. Up just to the vestibule. A little bit of bleeding on that one, so that's normal. We might get a little bit sometimes if you hit the periosteum, the layer overlying the bone. There's some vessels in that you might get a little bit of bleeding, but not much. That's okay. Normally you don't get a whole lot of bleeding from the lip. The tongue is where you could get a significant amount of bleeding if you go too wide or if there's like a weird vessel. So I'm going to defocus, try to hit that, get it to stop bleeding just a little bit there. Under here, start in the middle. It's pretty tight. We're going to release the top. We don't release the bottom of the Eiffel Tower. The bottom of the Eiffel Tower is not normally needed to release. So there you can see the fascia is releasing, the mucosa, that top layer. Now we're going to check it and feel for it. Still a little bit tight maybe, so I think we might hit a little bit more, but it was okay. So it felt smooth when we did it, so we're good. Always feel for that fascia though, make sure it's good. If you feel something tight, you can hit it again just for a second if you need to touch it up. Here's a couple of little case studies, but here's a 2-week-old male. So here's, again, our infant form. Falls asleep middle of feeding, slides off and on nipple, hiccups a lot, passy falls out, snoring, baby moves a lot, seems always hungry, lip curls under, gassy, nose is congested, takes over an hour to feed him. Bad pain, so I'm thinking, okay, probably tongue tie, lip tie, and then probably a posterior tongue tie, right? Because it's bad pain. Oh, this one got me. So occasionally it is a to the tip tongue tie with bad pain, but most of the time, if they say it's bad pain, it's a posterior tongue tie. Blanching of the tissue, this is afterwards. So again, this is the release currently. Like I do a little bit smaller now on the lip. Tongue, you want to get that full range of motion. So lay flat diamond right there. We did not take any muscle on this baby. We don't take muscle on babies, just the fascia and the mucosa, the lining of the mouth. Afterward, deeper latch, less falling asleep, more spit up because they got more milk, much less pain. It's like 3 now. Passy stays in better. They were happy. Here's this exact baby. This is a video of that baby. So again, same thing. Just right in the middle. Lift up on it. Lots of tension. Move nice and slow. Just kind of releasing that tissue. And then the tension, it just kind of like separates it out. You're almost just like nicking the tissue. And then the elevation or like tension is what's doing it. Look how tight that is. Oh my word. Super tight. And so here's zoomed in. You can see, woo, hello. That was really tight. And then we're going to check it. And we get a little bit above and below when it's to the tip like that, just so they don't have a small little tissue tag. So right there on the gum pad, we'll get a little bit of that tissue. Otherwise, they'll have like a little piece of tissue forever that's just sitting there. So we don't want that. And then much better mobility now. So there's the lip and tongue afterward. Here's a 2-month-old. This is the very next patient that same day. This is on a live course day, but trouble bottle feeding. So this breaks my heart. Are you presently breastfeeding? No. How long since you stopped? 1.5 months. So she tried for a couple weeks. It was so hard to breastfeed. She wanted to breastfeed, but now he's still difficult to bottle feed. So switching to a bottle does not miraculously solve the problem. They pop off and on the nipple. They're gagging, choking, hiccuping a lot, gumming or chewing the nipple, passy falls out, snoring, short sleeping, moves a lot in her sleep, like all the check marks, right? But notice which one they didn't check. Baby is gaining weight. So unfortunately, sometimes the primary care providers will say, oh, Mom, he's gaining weight. It's fine. Just leave the tongue tie. Don't worry about it. But these people are on the struggle bus with like 15 check marks. It takes an hour to feed him every 1.5 hours. And he's frustrated and gassy and colicky and refluxy and clicking. It's like all these things, right? Lots of things. Let's see. Hopefully it's a less obvious tongue tie, right? Maybe just the primary care provider missed it. And oh my word, like that is thick and super tight. That should have been picked up, like in the hospital picked up and treated or advised the parents to get it treated. Pretty good sized lip tie, although it's not as impressive as the tongue is. But there's the lip afterward. Here's the tongue afterward. Look at that. Much better elevation. So again, this is for about a year old, this case, but like these patients were back to back on a course day. I got a nice video of it, but look at this. So 10 pounds, 3.5 ounces. So like almost up a whole pound in like a week, right? Less falling asleep. Normal weight gain 7 ounces in a week. Almost up a pound in a week. Slides pops off nipple less colic. That's a blessing. Less reflux, less clicking, less gassy, better weight gain, less hiccups, less gumming, sleeping longer, less snoring. Again, also a blessing, sleeping longer for the baby. But less moving in their sleep, nose less congested, and less frustrated. So all kinds of really good things there for this baby. Here's the video. Here's how we did it. So again, it's the same thing over and over. Start right at the insertion point. Lots of tension. Laser safety glasses. Like baby, is help. Someone's holding their head. There's someone suctioning. Someone's filming for this one. So it's a whole production. But we did not put the baby to sleep. Nothing like that. And then let's check the tongue. Super tight. We'll get isolated well before we activate the laser. Now this one you'll have to do a little bit. And then sometimes you have to stop and check. Make sure you're off those glands. So we'll get a little bit here. It's still really tight. It's not laying flat yet. the Wharton's ducts are still pulled up into the frenum. We'll touch up a little bit of that off the gum pad there. Make sure it's not just flapping. Lift up all the way. Now lifts up much better. Feel it. Make sure it's nice and smooth. Mom and baby be much happier because his tongue can move now. So it's a nice service for the parents and the baby because it can cause lifelong issues, right? Here's a 3-week-old. So shallow latch to the breast, sliding off and on the nipple. Like, again, they're on the struggle bus. Now, this one took 3 weeks to regain birth weight. They give him 2 weeks to regain. I'd say if it takes longer than 1 week, that's probably a red flag. Something's off. But 3 weeks to regain birth weight, that's bad. Lots of in utero hiccups all the time, mom said. All the time. Mouth breathing, restless sleeping, projectile every feeding. So that's probably why we're struggling to gain weight, right? If they're struggling to take in milk, often tongue-tied babies get about half as much milk as a non-tongue-tied baby. And they're spitting up everything they do get, then that's a problem for weight gain. Pumping the last 3 weeks, 9, the worst thing ever. Bad pain, mastitis, the worst case that urgent care had ever seen. Postpartum depression, lots of issues here. They're on the struggle bus. Now, look, there's nothing there. This one's not obvious, right? Bad pain, there's hardly any, and I'm pulling up pretty good. There's not even like a definite string that popped up. A good sized lip tie. Again, so I'm thinking the lip tie is probably these issues. The tongue tie is probably these issues, okay? So we released it. The tongue does lift up higher now. It's a better, elevation of the tongue. The lip lifts up much better. And so let's see what happened. Well, this is 6-day follow-up. Okay, wow. Weight at the initial visit was 8.1. Now it's 8.13. This baby was not gaining weight well, okay? And so now we're up 11.5 ounces? So that's much better. That's better than normal weight gain. Was projectile before 8 times a day. Now only spit up 4 times in the last 6 days. It was 8 times a day. Less hiccups, much better. I'm telling you, the hiccups is a thing. Less reflux, less clicking, less spit up, deeper latch, less gumming, passy stays in better, milk leaks out of mouth less snoring. For mom, less nipple distortion damage, much less pain. Was a 9 out of 10 before, now it's a 1. From that tiny little posterior, not obvious tongue tie. It's crazy. Better milk supply, up 7 ounces. I mean, all kinds of really good things. Less plug ducts, less infected nipples. Sounds terrible, but mom is very happy because it's much better. All that to say, it can be done incorrectly with the laser too. So this was done with the diode incorrectly. This one, was posted on Facebook for everyone to see, but they used silver nitrate to stop the bleeding, significant post-op pain. I mean, nursing strike. You could be looking at a lawsuit with that one. That's not good. I don't know who did that, but don't do that. We don't even keep silver nitrate. We never had to use that. But you can do it wrong. So make sure you do it right and get proper training first. Briefly, for laser safety, you have to have a laser safety officer. That's me. See my badge there. Proper eyewear for doctor, assistant, parents, and of course the patient. Proper evacuation system, a laser in use sign, and the doors have to be closed. So here's a 2-year-old baby or kid. I don't know. He's still like a baby kid. No general anesthesia needed. No papoose needed. Just topical. We're going to release it. Here's the video. We have parents present for 12 months and up. We'll have the parents present. It's so quick. By the time he realized it's hurting, we're done. So release it. And I should have used a tooth chair because I got bit right there. For the video, I was trying to show it nicely, but we use a tooth chair always now. Got bit for that one. So trial and error. Live and learn. Here's the next one. Here's a 2-year-old male. Has his own language. Lots of speech issues. Notice issues as a baby. Painful nursing. Milk leaking out. Nipple shield. Clicking or smacking. He would throw up. He couldn't do solids. Now he's a picky eater. Packs food in his cheeks. Spits out food. Sleep issues. He moves around a lot. Sleeps in weird positions. Wakes up easily. Snores sometimes. Strong gag reflex. So I'm thinking probably a tongue issue. Lip tie. No issues on there. So let's look. Okay, so lip tie looks good. There's no gap. He can brush the teeth. Keep them clean. No lip tie issues. But that tongue is very tight. I'm kind of surprised no one noticed that. He's 2 years old now. So we released it. Notice it didn't lift up at all before. Now it flips all the way back. It's like off the screen. High. So we give him better. We treated the tongue restriction, gave him better mobility. Now we're going to hope for some symptom improvements. You don't always get them, but often you do. This is 10 days later. This is the same exact day as those other 2 patients before. But eating more food, finishing meals better, trying new foods, Used to wake up and join mom in bed, now sleeps all night in his own bed. That's nice if you're a parent. Less stuttering, so they were happy. Here's the procedure on that same child. Look how tight that is. So I did a tooth chair for this one, a mouth prop. We released that fascia. And then once you can't see it much anymore, you feel it and see, okay, it's still tight right there. Lots of fascia. See how thick that is? So we'll release that again, a little bit more. Get that median lingual septum a little bit between the genioglossus. Still a little bit of tightness on his right side, so we'll touch that up a little bit. There's a vessel over there. Don't want to do any more there, so we stopped. It wouldn't be dangerous per se, but it could make a good mess. It could be dangerous, but it could make a big mess. Because a 2-year-old, it's really hard to hold gauze pressure if you hit that deep lingual vein, so don't do that. Aftercare. So oral wound healing is rapid, heals by secondary intention. Mom should nurse right away. The wet scab can look like an infection or pus. Often there's increased drooling for a few days up to a few weeks. Tylenol and Motrin. If they're over 6 months, you could do Motrin, but we dose it by weight per pound, so it's a 1/4 ml per pound, right? Skin to skin, ideally nursing, but just get milk in them however you can. It's normally sore for a couple of days. We say 1 better feed the first day, 2 better feeds the next day, 3 better feeds the next day, but it often takes about 3 weeks to relearn. And then we call everyone. They have my number. I call everyone to check on them that night. If you don't do exercises, it won't work. If you don't diagnose and assess properly, it won't work. If you don't treat it properly, it won't work. If you don't follow up properly, do a deeper stretch, it won't work. So the exercises we recommend 3 weeks. We normally say just 4 times a day. I'll cross that out. About 4 times a day for a baby. For a child, it's 2 times a day. Really quality over quantity. I'd rather have 2 high quality stretches than 6 mediocre stretches, because you got to actually stretch the whole thing out. But quick, 5-10 seconds. Keep it playful if you can. Lift up the upper lip so the whole thing is open. Firm but gentle pressure right on it, back and forth like a rolling pin. For the tongue, come from behind, cradle the head with the palms. Hold the lower jaw with your left thumb, and then your right index finger straight down on the floor of the mouth, and then like into it and up, almost like a Heimlich, or like you're scooping, like a J shape. That's key. We always show the parents before they leave, have them put on gloves and practice too. Because they just watch us do it, we make it look easy because we do it all day. But have them put on gloves, and then they can really learn by experience. For toddlers to teens, again, 2 times a day for about 3 weeks. If it's really tight, like to the tip, we may have them do 4 weeks. Same for babies. If it's really tight, a larger wound, maybe 4 weeks for that baby. So it depends. It's just a guideline. Minimum once a day if it's like a uncooperative autistic teenager or something, minimum 1 time a day. Best results obviously work with a team approach, so speech therapist, myofunctional therapist. They'll do the myofunctional exercises. Often it's 2 times a day or as directed by the therapist. We try to see everyone back at a week. Most of them, about 90%, have lost some degree of mobility, and we'll do a stretch on them in the office, and you'll see it open up. Might have some red stuff, we'll say, might bleed just a little bit, and that's how you know it did open back up. Complications, so bleeding. The best defense is a good offense, so stay midline. If you do see a little bit of bleeding, don't try to ablate more with the laser. That will make it worse. Don't get your diode out and try to do that. Again, how do I know? From past experience. Don't try to take ferric sulfate and get it. Just hold gauze pressure 10-15 minutes if needed. That's the best option for bleeding, but always try to stay midline too. Nursing strike, often the Tylenol dose is wrong, so it's like an 11-pound baby and mom gave him 1.25 because for 6 to 11 pounds it says 1.25. That makes 0 sense because magically at 12 pounds you can go to 2.5. So 11-pound baby, we give them 2.25, right? If you calculate it out, milligrams per kilograms, that's how it works out. It's a 1/4 ml per pound. So 6 pounds is 1.25, 7 pounds is 1.5, 8 pounds is 1.75. Also, don't gut too deep or take muscle. That'll make it hurt more. Reattachment, have the parents practice the stretches, follow up at 7 to 10 days, and deeper stretch most of the time. Our reattachment rate is around 1% that we have to redo with the laser. Deeper stretch, that's most of the time we have to do that. And then parents realize they need to push a little bit harder. Also, be careful about the veins. So this is the deep lingual vein here. Don't hit that. That would be bad. It would be a mess. If you just nick it a little bit, do not try to hit it more. Again, but the best thing is just holding gauze pressure for 10-15 minutes. You can have your assistant do that too, but if you put pressure and take it out to check it, put pressure again, take it out, check it. If you're taking a Band-Aid off and on, it'll keep bleeding. Large midline vessel. So this one was kind of out of place. We released and it was right in the middle of the release, so you can see that, an aberrant not where it's supposed to be, blood vessel. So you see that with the laser, you can stop, but if you're using scissors, you're cutting that, you would just see red and you can't tell there's a larger vessel underneath because you're not able to dissect as well. We have perfect visualization with the CO2 laser, but there's no clue, no tip off there'd be a large vessel right in the middle. Here's another one. This is an adult we did. It's kind of interesting. Better nasal breathing after we released her lip tie. Very significant tongue issues. She had sleep apnea and other issues. Look at that. Nice release. Nice sutured up there. She came back like a couple months later. It was tight again. So even with sutures, they still have to do stretches afterward, and it can still grow back some. So it's much better elevation than it was, but we released it again. Got even better elevation. But look how big this vessel was. Whew, hello. That's the deep lingual vein right there. You do not want to mess with that. You can take your gloved finger and just kind of move it out of the way a little bit. If you need to get a little bit more, you can do that. That's a tip you learn along the way. But don't mess with that too much because it'll bleed everywhere and make a mess. So how to get started? We're almost done. Get trained, screen your existing patients, start with an easy case. During maybe a general anesthesia case, if you're a pediatric dentist, you can use the electrosurge. It's 12 to 15 cut as the settings. Don't start with babies or toddlers. Choose a cooperative patient. That's key. Try a lip tie first. There's fewer risks, less risk of bleeding or paresthesia from the lingual nerve. Don't do your team members or family members first. I would say wait at least 50 cases before you're done. Practice, see everyone back for follow-up, and adjust your technique, adjust your stretching technique based on your findings. Trial and error. Scheduling. So how to get started. Ideal is block off an hour of time for a tongue tie procedure. So you could do it on a half day, you could do it on a full day, or you can just work it into your schedule. It basically take an hour of op if you're a dentist, hour of fillings or crowns, and substitute in a tongue tie. Babies will be in the office about an hour and a half because they need time for nursing or bottle feeding. Schedule follow-up appointments. They're about 30 minutes, but it's only about 5 minutes of your time. Children and adults in the office, they're about an hour. So we try to fit in nursing dyads, the mom and baby, or triad, mom, baby, and dad, with significant struggles, like if it's a dental emergency. So we try to work them in wherever we can, if they're having a lot of struggles. So make sure you have enough rooms. We actually have 5 now, consult rooms, and then 1 treatment room. 5 is a good number. Dental billing. So you can bill it dentally, but it leaves you open for audits because you'll be an outlier. Ask me how I know. We've been audited just a few times. Lip tie code, there's the tongue tie code. They just changed it a couple years ago. But most plans, keep in mind, they have an exclusion for congenital anomalies. They're probably thinking like a cleft lip or palate, but really a tongue or lip tie is a congenital anomaly too because it's present since birth and it shouldn't be there. So this is from our Blue Cross provider manual for our state. Dental services with respect to congenital malformations or for cosmetic reasons are excluded, no benefits. So they will pay for these codes, but if you bill them out, they could come back at any time and recoup those payments and claim it's medical, right? So don't do that. Better option is to bill it medically because we're doing it for babies that don't have teeth. They're doing it for feeding struggles, so feeding problems there, for speech issues, for whatever, sleep issues. Those are medical issues. So I'll bill it medically. Here's the codes. You can screenshot it or take a picture. You put them in, basically, we bill out, normally it's about 30 minutes of our time, we bill a level 3 exam. Tongue tie release, that's like using a laser, or scissors, whatever you want to use, but if it's for frenectomy, it's 4115. Frenuloplasty, so if I do a horizontal to vertical frenuloplasty, I suture it closed, we use that code, and then the lip tie release is 40819. What do? You get a CMS 1500 form, has to be on red paper, that's very important. The parent fills out the top part, the provider fills out the bottom part. Diagnosis codes go here. Procedure codes go here. Here's your procedure codes. The modifier code. The only modifier we really use is a 51 modifier. It was on that previous page. Basically, it says we did 2 procedures in the same day, so it goes by the second procedure. The charges, your NPI, your practice location, all that stuff is filled out there. The easiest way to do that is get something like Form Docs. I'm not paid by them. I've never talked to them before. This is just what we use. You can get the light version. It might have gone up with inflation, but the CMS 1500 Lite. So type in Form Docs, CMS 1500. This pulls up. It's a software for Windows. And basically, you can create different templates. Then you just change the date of service and change the patient's name and their birthday. and then whatever you did on them, and you can have it, it's all in there with your information on it still. Makes it very easy. You print it out on a red form, give it to the parent. They can fill out the top portion and mail that off to the address on the back of their health insurance card. Hopefully they get paid something. If you guarantee they'll get payment, they won't get anything. Fees. Consultation fees, around $75 to $150 typically. Medical consult fees around $250, but typically not for a cash patient. Procedure, $375 to $500 per site. We don't charge for buccal ties. We don't charge for follow-up visits. We don't charge if it has to be redone for any reason within the first year. Even if the parent did terrible stretches, we'll just tell them that the baby healed really fast or something, and then we'll do it again for free the first year. But yeah, so average dental fee is like $230, or Medicaid in our state's $185. But it's a long story. We don't bill for Medicaid anymore. We're out of network with Medicaid for the Tongue Tie Center. So we have lots of patients with Medicaid. We do give them a discount because they cannot mail off a claim to Medicaid. They're not going to reimburse them. But we're out of network with Medicaid, so we can they can pay us, and then it works out. But anyway, total out of pocket plus consult, probably $800 to $1,000 is a normal fee for 2 areas. If it's just one area, lip or a tongue, it's probably $450 to $650. So pediatrician referrals used to be less than 1%, mostly Dr. Google. That's a joke. Now maybe 10% of patients. We tried lunch and learns with pediatricians. We got a booth at the state conference. I thought I was going to get a lot of tomatoes thrown at me. I was pleasantly surprised how many pediatricians were interested in talking about tongue ties and stuff. But there was a lot of that just like shook their head and walked past and ignored us. So if you have tough skin, you may consider that, but maybe not. The better thing is just to send out letters for every patient. So we send a letter, it's on the next slide, to every patient, it's pediatrician afterwards, saying what symptoms they started with, what improved, and then it's not an infection. Call us if you have any questions. If you want a copy of the book Tongue Tied, we'll get you a copy of the book Tongue Tied. What's funny is this is a fax referral we got from a pediatrician, and basically it says, referral, Dr. Baxter, Alabama tongue tie. What's funny is they thought I was an ENT, so they put ENT on there. I guess in their mind they thought, we had to be an ENT if we're doing this, but anyway, I thought that was funny. Here's the letter we send out. Basically, infant had these issues, mom had these issues. We did the laser, mom nursed right away, noticed an improvement in the depth of the latch. The wound will heal up, it's not an infection. If you have any questions, contact us. If you want a copy of Tongue Tied, contact us. So we just send this out. We don't send pictures of it. We used to. Just a basic letter. And they probably don't even read it, but maybe the nurse at the front will read it. Maybe she's the one that gives out the referral cards, and we can help other patients that are struggling too. Last slide here, team approach, lactation consultant, the dentist, the release provider, if that's not a dentist, orthodontist, speech therapist, OT, myofunctional, ENT, pediatrician, sleep physician, physical therapist, chiropractor, any others. I'm sure I'm forgetting some, but the more team members, the better it'll work. So proper assessment and evaluation is critical. Symptoms and function are more important than the appearance. Screening should be conducted at hygiene visits or well child checks. You have to document everything relating to tongue ties, even on hygiene visits. Because like oral cancer screening, if you don't pick up on it and they have a obvious tongue tie, you could be liable. It could be a missed diagnosis, right? So like you want to, just like oral cancer is like, 1 in 1,000 people, 1 in 10,000. It's not as common as a tongue tie, which is probably 1 in 4. So check everyone. But the sooner the problem is addressed, the more team members, the better. A precise release, follow-up, adjust your technique, and your patient instructions. I would bill medical insurance for less billing and patient headaches because we did dental for a few years, and it is lots of headaches for your team members as well as the parents. So always protect yourself, take pictures, good consent forms, all that stuff. Talk to your malpractice insurance, protect your patients, make sure it's done properly, and please protect our specialty. Don't do a crappy release on someone. Don't just laser everyone. If they need it, obviously do it, but have a full conversation before just doing that. So that's all. Hope you guys enjoyed this presentation. I hope it was informative. Maybe you learned something, even if you've been doing this for 10 years. If you guys do want to get in contact with us, you can call our office, you can email us. If you do want to download the forms or Tongue Tied, you can use the QR code or tonguetieal.com/professionals. We do have a Tongue Tied Academy code. It's 10% off, so it's actually about $280 off Tongue Tied Academy, the full version. The version for therapists, it's about $50 off with that code ICAP22. So the therapist version is about 13 hours, leaves out all the treatment stuff. The full version is 25 hours. And we donate all that money to charity. So I'm not just like trying to make money for our course here. But it has helped hundreds of dentists and others learn more about tongue ties so they can better take care of their patients. So again, hope that was helpful. Reach out if you have any questions, and we'll see you soon, hopefully next time in person. Take care.